Muchísimas gracias por su participación.
I'm Marco Falcone. I'm an infectious disease. I'm an associate professor of infectious disease at the University of Pisa, Italy. And my clinical activity and research activity is focused on the infection caused by multi-drug resistant microorganisms, particularly nosocomial infections. And I'm very interested in the correlation between the mechanism of resistance and the clinical outcome and response to drugs of patients with nosocomial infection. First, I want to thank you for the invitation. It's a great pleasure for me to be part of this event, the Jornadas Hospitalarias. I also speak Spanish because I was in Spain some years when I was a student, but it's not so good. And I think that it's better for you and also for me to speak in English, but I hope to be in Argentina in the next month or next year and to be in presence in the next edition of your Congress. And this is the disclaimer. My conflicts of interest. And then I start with a clinical case. Is a male, 67 years old, with a pancreatic adenocarcinoma, who underwent a neoadjuvant chemotherapy, and the surgeon decided to perform a duodenocephalopancreatectomy. And after this intervention, that is a very invasive intervention, the patient is transferred to ICU. 2 days after surgery, fluid collection positive for E. fecalis and E. coli started piptazo and improved, the clinical condition improved. But after 7 days after surgery, the rectal swab becomes positive for carbapenem-resistant Klebsiella. And what happened? 11 days after surgery, a septic shock occurs. At the computed tomography, multiple intra-abdominal collections are visualized. A drainage is placed in therapy, and the patient starts vancomycin 2 grams a day plus meropenem 1 gram 3 times a day. 24 hours after blood culture collection, the lab called the ICU and said that blood cultures are positive for gram-negative bacilli. Clinical condition worsened. 48 hours, the blood is positive, blood culture are positive for KPC Klebsiella, and the clinicians decide to add colistin to therapy, 9 million downloading dose, and then 4.5 million every 12 hours. And 96 hours after blood culture collection, the patient developed a septic shock, not responsive to therapy, acute kidney injury, and death. And this is not a successful patient, a successful case. This is a severe nosocomial infection caused by bloodstream infection caused by KPC Klebsiella with subsequent death of the patient. This is a failure from the clinical point of view. But my first question that I want to discuss in this presentation is, what did I do wrong in this patient? Which are the critical point of the management of this patient and what we can improve? And I focused on 3 points. The first that I want to discuss now is the time to appropriate antibiotic therapy. Why I speak about time to appropriate antibiotic therapy? Because we performed this study in some years ago, last year, in patients with KPC producing Klebsiella pneumonia bloodstream infection in ICU. And as you see in this slide, if you start an antibiotic therapy with at least one agent active against KPC, during the first 24 hours, the mortality is about 30%. And the mortality rise to 37% if you are able to give to the patient at least one antibiotic active in vitro within 48 hours. But if you delay the administration of an active antibiotic therapy after 48 hours, the mortality is very, very high, is more than 50%, up to 80%. And then there is a strict correlation between the blood culture, that usually if clinicians perform blood culture examination when the patient has fever or sepsis syndrome, and the start of an appropriate antibiotic therapy. In patients with KPC Klebsiella, as in other infection, it's very crucial to start early an appropriate antibiotic therapy because mortality is directly related to the delay of antibiotic therapy. In this, in the same paper, we demonstrated at Cox regression analysis that every 24 hours of increment in the time from blood culture collection to delivery of an appropriate antibiotic therapy is a factor. This increment is a factor independently associated with increased death. Then it's crucial, it's really important to deliver early an appropriate antibiotic therapy. How we can do? It's really important to study the rectal colonization of ICU patients at risk for KPC, because usually it's very common the KPC first colonize the intestinal tract and then translocate to the blood or cause invasive infection. This is a simple score that was published by some Spanish colleagues that evaluate the admission to ICU as a factor, the invasive abdominal procedures, history of chemotherapy, radiotherapy, and the colonization at sites besides stool, 1 point risk for each additional site. As you see, it's very simple to calculate. And if you have a score more than 7, this study suggests to start a therapy active against KPC in all colonized patients. Then the score is able to discriminate patients who need an empirical therapy active against KPC compared to patients that probably have a low probability to develop a bloodstream infection caused by KPC. And in our patients, these patients is risk award 9. And then it was really appropriate and really rational to start early an antibiotic therapy, including antibiotics and active against KPC. Then the first important message from this case is that you have to evaluate the presence of intestinal colonization by KPC, and you have to start an appropriate antibiotic therapy, including drugs active against KPC, if the patient developed a sepsis syndrome and the patient has some risk factors that are associated with the risk of bacteremia from KPC in rectal catheters. Okay. And this is our algorithm in Pisa. Pisa is a teaching hospital, my hospital of 1,200 beds. There are a lot of ICU beds, and we have some, this is the approach in the ICU. We perform rectal screening twice weekly in all patients in ICU. When the patient develops a sepsis syndrome, there is a clinical suspicion of infection, we evaluate the risk score. If the risk score is more or equal to 7, we start ceftazidime-avibactam as a single therapy or combined therapy, combination therapy. This is in this decision is of the specific clinician, physician in charge, and we have, as soon as we have a targeted therapy, we de-escalate according to the susceptibility profile of the isolates. And this is the really important for me as a message of this case. If you know the rectal colonization of the patient and the patient has KPC in the intestinal tract, you have to start an active therapy. Ceftazidime-avibactam in my hospital is considered the first choice. I will explain why, but you can also start colistin if you prefer. If your hospital there is no availability of ceftazidime-avibactam, but you have to start an appropriate therapy, because if you wait, and there is the delay from the collection of blood culture and the start of antibiotic therapy, the outcome is very poor of these patients. And really important, in my hospital, we apply de-escalation in all cases. If the patient has not a KPC Klebsiella, or if a Klebsiella is susceptible to other drugs, we stop the empirical therapy and we adjust the targeted therapy according to the susceptibility profile. Really important, in my opinion. Second point, the first point is the time. Second point is the choice, which is the best antibiotic to treat a sepsis or bacteremia or pneumonia, severe infection caused by KPC or carbapenem-resistant Klebsiella. And my question is colistin still a good choice? Because colistin is a very old antibiotic that has been reused during the last decade, the last 2 decades, because the spread of KPC or carbapenem-resistant strains. But colistin was an antibiotic very old that has not been used because side effects and PK profile very difficult to predict, then is not a perfect antibiotic. First, colistin resistance as according to the use, most as more as you use an antibiotic in general, you select resistance. And this is true also for colistin, because the use of colistin in Italy, for example, there is 43% of resistance. These are data of the teaching hospital of Rome, where I worked until 3 years ago, and we have a resistance to colistin of about 50%. Then first, after the use of colistin, we detected in some countries an increase in the rate of colistin resistance. But the major problem for colistin is not just the susceptibility profile, but the safety profiles and the efficacy profiles. This is a study performed by Ryan Shields, colleague for US, very expert in the treatment of CRE and carbapenem-resistant infection. And as you see, he compared ceftazidime avibactam versus carbapenem plus aminoglycosides, or carbapenem plus colistin, or other. And as you see, both in the arm of carbapenem plus aminoglycosides, that is marked in red, and the carbapenem plus colistin, as you see, there is a high rate of acute kidney injury at 48 hours, at 7 days. And as you see, 57% of patients had acute kidney injury at the end of treatment in the carbapenem plus colistin arm. This is a very high proportion of patients who develop drug toxicity compared to 9 to 18% of ceftazidime avibactam. Then colistin is not easy to use because the renal toxicity. And we have new agents. New agents, the most used in the world, because it's been approved in almost all the countries of the world, is ceftazidime avibactam, and other options will be ready and will be useful in the next future, which distinguish avibactam from the traditional beta-lactamase inhibitors. Then this is a non-beta-lactamase inhibitor, is a chemical structure different from tazobactam, sulbactam, or clavulanic acid. And what is important is that avibactam, there is a non-covalent chain with the beta-lactamase that allow an activity also in strain producing KPC or other beta-lactamase. This is the panel of activity. Basically, ceftazidime avibactam is active against beta-lactamase serine enzymes of class A, including ESBL and KPC, and the class C, including MC. Is not active against metalloenzymes, then NDM or VIM or other, and is partially effective as a good activity, not full activity, but good activity against OXA48 and against class D carbapenemesis. This is really important because among the new drugs, the new beta-lactamase inhibitors, ceftazidime avibactam is the only one that's active also against OXA48 producing strain. And this is summarized from this slide, as you see, compared to ceftolozane, tazobactam, and meropenem, vaborbactam. The main difference compared, for example, to meropenem, vaborbactam, that is a good comparator with ceftazidime avibactam. OXA48 is in the spectrum of ceftazidime avibactam, while meropenem, vaborbactam is not acting against this strain. And also, it's also important to remark that ceftazidime avibactam had a very good activity also against carbapenem-resistant Pseudomonas aeruginosa strain. Then this is a really new option, not so new because we use it since several years, but it's a very powerful weapon against some multi-drug resistant gram-negative bacilli. Indications of ceftazidime avibactam are complicated intra-abdominal infection, complicated urinary tract infection, including pyelonephritis, hospital-acquired pneumonia, including ventilator-associated pneumonia, and important, this is really important, this is in Europe, is approved for infections due to aerobic gram-negative organisms in adult patients with limited treatment options. In some countries like Greece, like Italy, like Turkey, Romania, or other countries, also France now or Spain, the prevalence of carbapenem-resistant bacteria is very high. And then we claimed the need of new drugs against this microorganism. Data about efficacy in ceftazidime avibactam in the treatment of CRE bacteremia comes first from US. This is another study of Shields that compared the previous study that also mentioned that compared the patients receiving ceftazidime avibactam and other regimens, including colistin or carbapenem plus aminoglycosides. And as you see, he showed for the first time that patients receiving ceftazidime avibactam had a better outcome, a higher rate of clinical success at 30 days. But these are another US study from David Van Duyn, really distinguished scientist from US, compared the efficacy and safety of ceftazidime avibactam compared to colistin. And as you see, there is a difference, first in the number of hospital deaths favoring ceftazidime avibactam, but there is a great difference in terms of safety, in terms of patients who develop incident renal failure. And this is the second point. There is a problem of efficacy associated with colistin, because colistin is really different. It's really difficult to determine the exact dosage in a patient because its pharmacokinetics is erratic and it varies in different patients. And also studies about PK, PD analysis of colistin are limited because there are several difficulties to assess the perfect dosage of colistin. And second, the safety, because the renal failure is very, very common. Clinical study from Italy confirmed the role of ceftazidime avibactam as salvage therapy in patients with KPC producing Klebsiella. And also in my study that I previously showed you, we evaluated the impact of colistin containing of ceftazidime avibactam containing regimens. There were no differences in terms of 30-day mortality. There was some difference, 44 compared to 23, but this difference was not statistically significant, probably because the number of patients was not so high. But when we considered a composite endpoint, including both death or nephrotoxicity, the patients that received ceftazidime avibactam had a significant better outcome compared to patients who received colistin containing regimen. And then this is in the view and very in accord with the new and most recent data suggesting an improvement of the outcome of a KPC bloodstream infection KPC producing Klebsiella blasting infection in patients receiving ceftazidime avibactam compared to colistin or other regimen. Ceftazidime avibactam is also active, as you know, against other bacteria, for example, OXA48. OXA48, if you have an antimicrobial susceptibility of the isolates, of the OXA48 isolates to ceftazidime avibactam, as suggested from this study that evaluated only patients with infection from strains with MIC to ceftazidime avibactam in the range of susceptibility, this clinical experience showed a very low mortality, a very good clinical response to ceftazidime avibactam. Then probably you can treat OXA48 infection with ceftazidime avibactam if the MIC is within the range of susceptibility. And also, ceftazidime avibactam has been also evaluated in infection other than CRE, for example, ESBL, Enterobacteria, for example, Pseudomonas, and preliminary data suggest a very good impact of these antibiotics, not only in KPC associated with infections, but also in infection caused by other bacteria other than CRE. The last point that I want to discuss in my presentation is the appropriate dosages, okay? Appropriate dosages because, as you know, beta-lactams, there is the risk during sepsis in septic patients to underdose beta-lactams, but data coming from the phase 2 and phase 3 studies and also from the post-marketing experience suggest, at least published data, that standard dosage recommended in the normal actually recommended 2.5 milligrams every 8 hours are able to have a good exposure of the drug in almost all situations, in patients with normal renal clearance, in patients with mild renal impairment, in patients with moderate or severe renal impairment. This is very good. These are the standard dosages. And also there are other data suggesting that standard dosages are able to ensure a very good exposure to the drug, also in patients with high Kappa-Schiff score, with severe inflammatory respiratory syndrome, or with an increase of WBC or white blood cells. And this is also my personal experience that I don't show you, but we evaluated ceftazidime avibactam also in critical patients in my hospital, and the exposure to the drug was very good using standard dosages, not increased dosages in almost all cases. And this suggests that standard dosages are useful and are able to ensure efficacy, clinical efficacy, and also pharmacokinetics good exposure. In conclusion, I tried to explain you the importance, first importance of an early administration of the appropriate antibiotic therapy in ICU acquired infection caused by MDR and specifically by KPC producing Klebsiella pneumonia. This is a goal of the physician in ICU to start very good at the active antibiotics as soon as possible. And it's really important in this view to achieve this goal. It's really important to stratify the risk with a simple score and to analyze the colonization. Intestinal colonization is a very good investment to spend some money for the performance of rectal swab, if possible, molecular rectal swab. Then you can also discriminate between KPC or NDM or OXA48 or VIM or others. But this investment, this money that you spend performing molecular tests is associated with a reduced mortality and a better empirical initial therapy, because you start antibiotic therapy with strong drugs against KPC when the patient develops fever and when the patient develops a septic syndrome. And you have not to wait for the final susceptibility tests that in some cases, in some hospitals, it lasts up to 3 days from the collection of blood culture and the final response of blood culture. Newer drugs such as ceftazidime avibactam appear to have a very good safety profile and better efficacy. This should be confirmed by randomized clinical trials. Very difficult to perform randomized clinical trials in this setting, but this is what is available, and this is the conclusion of the majority, almost all papers published in the literature during the last 3-4 years suggested a better role of ceftazidime avibactam compared to colistin or comparators. And the PK analysis, this is very important, demonstrates that the dosage regimen recommended in the ERCP of the drug is very good, robust, and ensure high target attainment. I hope that in the future we will be able to perform the very better control of infection control, because the real key to reduce nosocomial infection is to implement infection control procedures and to prevent infection by multi-drug-resistant microorganisms such as KPC producing Klebsiella. But if you work in a hospital with these problem of infection by MDR, the use of these new drugs such as ceftazidime avibactam is really useful to improve the outcome of our patients. Thank you very much for your attention, and I hope to see you in the question and answer corner. Thank you.